All right, well, thank you everyone for hopping on. Again, welcome to day 2 of the CSOHIMSS Fall Virtual Conference. I don't believe I've had a chance to meet most of you yet. My name is Megan Anderson Baker. I am the memberships chair this year for CSOHIMSS. I'm very excited to kind of step into an official board position for the very first time. I have the wonderful honor of getting to introduce my colleague, Melissa Weant from CoverMyMeds. Melissa has a really wonderful presentation put together just to talk a little bit about the medication access impact from COVID-19. Again, an extremely timely and interesting presentation. But I'd like to take this time to introduce Melissa and get you guys acquainted with her as well. Melissa Weant, PhD, leads our provider analytics team at CoverMyMeds. She's responsible for providing data-driven insights to aid prescribers and getting patients on the medications they need faster and more efficiently. Prior to joining CoverMyMeds in 2016, Melissa spent 10 years as a paramedic and was the director of research at the National Registry of Emergency Medical Technicians. In her time in this role, she focused on occupational health and safety research with a specific interest in understanding the first responders' willingness to respond to disasters and protecting the mental health of pre-hospital providers. Outside of presenting her research both nationally and internationally, Melissa worked to assess the willingness of pre-hospital care providers to respond to a potential Ebola patient during the 2014 epidemic, creating a dashboard that was shared monthly with the Secretary of Health and Human Services. Melissa earned her Bachelor of Science in Molecular Biology from Kent State University, Master's of Science in Environmental Health from The Ohio State University, and PhD in Epidemiology from The Ohio State University. Outside of work, Melissa also enjoys chasing after her 2-year-old son and new puppy with her husband, organizing everything she can get her hands on, and ballroom dancing. And without further ado, I will go ahead and pass it on over to Melissa. Melissa, you can go ahead and share your screen and get started with your presentation.
I will do. Thank you, Megan. Let's see, slideshow. Let's get everything organized. Seeing the deck?
Yep, you are good to go.
Awesome. Well, hello, everyone. Again, my name is Melissa. This is Batman behind me. I guess he is deciding that he will participate as well. And we're really going to spend the next hour today chatting through some of the impacts that COVID has had on medication access. And welcome, and more importantly, thank you. As Megan mentioned, I've spent a lot of my career working to understand the response, and not just the response, but the willingness to respond to large-scale disasters, both natural and man-made, and within those, epidemics and pandemics. And gosh, it really takes a toll on you. You're thrown into a new and oftentimes dangerous situation, and we can prepare and we can train, but it's different when you're living and you're experiencing it. And you're all here today with me, which tells me you have shown up every day over the last 8 months. You know, you've put yourself at higher risk for COVID, and you've put your families at higher risk, and that is seen and so very much appreciated by so many. And saying thank you doesn't speak to it. Those are too small words for such a gravity of a situation. But if you haven't heard it recently, thank you so very much. In COVID, that's what we're really going to focus on today, specifically within COVID-19, that medication access barriers. Our patients, now more than ever, are really struggling to get the medications that they need to live healthier lives. And you as providers are struggling to get the patients what they need. We're then going to talk about the shift that we are all feeling right now as our new normal and starts becoming our old normal. And lastly, what opportunities has the pandemic created to tackle some of the existing barriers and challenges we've already been facing, as well as some new ones. So medication access barriers, why do we care? It's always been a problem in our industry. So why are we talking about it today on the day that's dedicated to our current pandemic? And the answer to that is nearly half of the US population is on a daily prescription medication. And the Kaiser Family Foundation has estimated that 1 in 10 adults in the US has experienced trouble affording prescription medications, affording health insurance, or affording their medical bills since the current pandemic began. So, throughout the next few slides, we're really going to put into context where we were pre-COVID and then layer on what we're seeing post-COVID. So we all know that patients pay for their medication in one of two main ways. The first is health insurance and their prescription benefits that come with that. And the second is out of pocket. And we all know that there are patient assistance programs, copay cards, discount cards that are sprinkled throughout both options. And we'll talk more about that as we go on. But before COVID, patient medication or patient access to their medications was already tough. Here in the US, 109 million Americans were either uninsured or underinsured. That's 109 million Americans. These are folks that going to the physician's office, if they were even going at all, was exponentially stressful because they know if they needed a medication, they may show up to the pharmacy just to find out that they couldn't afford that medication. So we started with this horrible baseline. 109 million Americans is a lot. And then we woke up in March with the pandemic right out our back doors and our front doors, and it was everywhere in every facet of our lives. And the effects of COVID on this baseline were absolutely astonishing. Over a 12-week period after the pandemic began, first-time unemployment rates, those claims, they increased to more than 6 times what they were during our Great Recession. Now, this is 44 million claims in 12 weeks after the pandemic started. We are many more weeks into the pandemic now. But of these 44 million, we know that a little over 20 million of them, they lost their health coverage. These are a lot of numbers to digest, and I'm an epidemiologist. I love numbers, but I don't want to take away the human component by just talking about statistics. So let's add a face to these numbers. Picture this, a family of 4, Raymond, his wife, and their 2 kiddos. It's something that a lot of us can relate to. Raymond, for the first time, has lost his job, and with that, he lost his family health coverage. Thankfully, Raymond's wife is still working, but for the time being, right? But she isn't working full time because you know what? Kiddo care, that's expensive. And it just made sense for her to work part time and stay home with the kiddos a lot. And that's something that we can all relate with also. But because she's working part time, she can't get health insurance. So let's really think about what options are available to Raymond and his family. And there are a few options, and there is a way to extend your healthcare coverage throughout your employment, and that's COBRA. So that's one less stress for Raymond, right? No, no, it's not. If you elect to use COBRA, you become responsible for the full share, and not just your employee coverage, but your employer's coverage. And that's not cheap. And to say that's not cheap is putting it so mildly. In 2019, the average cost of an individual's individual coverage under an employer was $7,000. And over $20,000 for a family. So for Raymond, this means if he hops on COBRA to get his family health care, they'll need to pay $1,700 a month. This is not attainable for many who are suddenly without income. So if COBRA is not an option, what other options are available? Medicaid. The Affordable Care Act. But but there's a lot to this. You have to navigate the marketplace. It's a confusing world, even to the most educated individuals. Plans covered through the Affordable Care Act, they still cost money. A lot of people are having to make some really hard decisions right now with money, no matter how many incomes are contributing to their household. Money that you were counting on is gone. When you've got your mortgage, your utilities, your groceries, and your health insurance on the table, something has to go. And there is another option, and that's Medicaid. But it's not as easy to get as raising your hand and saying, hey, state, I need Medicaid. We're struggling. There's paperwork, there's waiting periods. Medicaid offices across the country were inundated with applications. To begin with, that's heartbreaking. So we started with a really rough baseline, 109 million Americans, and we increased that baseline by potentially 44 million Americans in 12 weeks, with not a lot of great options. And there's still yet another layer to this, and that layer is disparities within our healthcare system. If you think about what we just talked about, 109 million Americans under or uninsured. Again, adding 44 million Americans potentially to increase that. And something that we have to keep in mind through everything that we're talking about today and moving forward is that this isn't affecting Americans proportionally. This is overwhelming and disproportionately affecting certain racial and ethnic groups. And because there are systemic health and social inequities that have existed long before the pandemic, that's why this is happening. There's already racial and ethnic groups that are more likely to be uninsured when compared to their non-Hispanic white counterparts. And when we start really digging in, access to healthcare, the same groups that are likely to be uninsured also struggle to just purely access the healthcare system to begin with. And this is because of lack of transportation, lack of childcare. They can't take time off of work. There's communication and language barriers. And on top of all of that, if they get there, and there's often cultural differences between providers and patients. Income and wealth gaps, there are inequalities for high quality education. We know that, but we know that inherently creates wealth gaps. And specifically for COVID, we have a disproportionate representation of some folks from certain racial and ethnic groups that are in essential work settings. And because of everything else, there's limited job opportunities. So if you're an essential worker and you want to decrease that risk of exposure, the likelihood of you finding a job that it's not an equal higher risk of exposure and in that direct line of COVID is small. Housing, we have lots of folks that are living in crowded conditions, and that essentially makes all of our precaution strategies null. And we've seen all of these disparities just rear their ugly heads. We have Black Americans, we have Latinos, we have Indigenous Americans dying at 3 times the rate of which white non-Hispanics are. And I'm going to say that again, because I want you to take lots of things away from our time together today. But if there's only one that you take away, I want it to be this. At the very roots of it all, we are all here because we want to help patients. And we as an industry are not doing a good job at helping all patients. Black Americans, Latino Americans, and Indigenous Americans are dying at a 3 times the rate of whites from COVID. So through all of this, if you're still going to a physician, hey, that's a lot harder now. About a month and a half into the pandemic, we reached out to provider offices all across the country to really understand the impacts they were feeling due to COVID. And these are impacts that I'm sure all of you were feeling. It's crazy to keep adding more and more layers to all of this, but we've got to tell the entire story. If you're a patient who has managed to make it through all of these obstacles, you still have a few more to navigate. You know, a lot of your offices, about 44%, were only seeing patients on an as needed basis. So this means that you were making the best decision to see your patients in person or via telehealth based on the reason for seeking care. You were likely being asked to work in a narrower time frame, to take all of your responsibilities and fit them into a smaller window, because over a third of offices were decreasing their normal office hours. And lastly, 7% of offices were struggling to accept new patients. And I'm sure a lot of you were feeling just pretty cruddy about that. As providers, that doesn't feel good to turn away and not be able to accept a new patient. And it's important to keep in mind that all of these impacts, they're not singular. And in many cases, they could be additive. You know, in April and in May and into June, you were all likely feeling so much pressure because it seemed that everything was trying to stand in your way of taking care of your patients. And on the patient side, so this is scary. So let's bring Raymond back into this. His wife, still working. She's an essential worker. She's out in this world and she starts feeling pretty cruddy. That's terrifying. You're in the middle of a pandemic. We don't have good information on anything, and you start feeling bad. So that, oh gosh, your stress level is already through the roof. You know, they lost their health insurance. She doesn't have a primary care doc, so she starts calling around. The first couple offices that she talks to, and they're not accepting new patients. Ugh. Okay, so the next call is successful, but Raymond and his family don't have insurance yet. They're still, their application, you know, is pending at the Medicaid office. And the office that she found, they won't take her because she doesn't have insurance. So she keeps calling, and think about this. Your stress is just mounting. You feel horrible. You're worried it's COVID. You're worried you're going to give it to your kiddos and your family. And now you can't find a doctor to help you. But she keeps calling, and she finds someone to take her. But guess what? The only times they're open is the times that she really needs to go to work because she's now the single income contributor to her family. Geez, blah, there's just not a lot of really great options. And continuing from this perspective of the patient going out into this world, it's scary, especially in April and March and April, where we were trying to learn as much as we could about COVID. And if you're already chronically ill, super scary. Provider offices are changing the way they practice, you know, but they're still showing up. You all are showing up every day, because at the root of it all, we're here for our patients. And some of the work that we've done, we've estimated that 42% of patients have taken it upon themselves to cancel or delay an in-person appointment. This means in some cases, patients themselves are dropping down that barrier for medication access. You know, even more patients are staying home and connecting through their providers through telehealth. And we'll talk a lot about telehealth here in a second. So we've been talking a lot about baselines. An overwhelming majority of patients pick up their medications at a retail pharmacy in person. About a quarter of provider offices are reporting that one of the leading medication barriers they're experiencing is their patients are now unwilling to go to the pharmacy. Makes sense, right? This was in April, end of April, May, when we started asking these things, and people were scared. They didn't want to go to the pharmacy to get their medications. And we see that just that reflected when we talk to patients. Just under half have expressed interest and, hey, I don't want to go to the pharmacy. I want to use an at-home delivery option for their prescription meds. And we see all of this trickling down, and this story is really being told at the pharmacy. We've seen a 25% decrease in acute care prescriptions compared to just a 3% decrease in those chronic care scripts. Our acute patients are holding off. They aren't seeking care, or they aren't able to easily access that care. And again, full circle, if the patient gets through all of these other barriers we just talked about, and they show up to the pharmacy, 30% of our provider offices are telling us that their patients aren't able to afford their medications. About 1 in 5, or 20%, are really trying. Since the beginning of the pandemic, they've reported turning to a cash program to help offset that cost. So what does that look like for a patient? So let's talk about Raymond's wife one more time. Thankfully, she didn't have COVID. She had the flu. And that's rough in and of itself, but they caught it early. So she was a great candidate for Tamiflu. They show up at the pharmacy, and out-of-pocket cost for Tamiflu was about $100. And using Savings Seeker, she was able to get that down to $10. And that was doable for Raymond and his family. And they're in a success story. They were able to successfully navigate all of the barriers that we just talked about. But there are so many stories out there that aren't successful. And so we've talked about a lot of barriers, and because there was such a focus on all of the barriers COVID just dropped in our industry, we're seeing our industry shift, and we're all feeling that. We talked about how providers changed how their offices were handling patients. We've had to figure out remote settings, logistically work out how we're going to reach our patients that need us. And through all of this, we on the provider side, you as providers, really had to lean into technology. 85% of provider offices across the country told us that since the onset of our current pandemic, they started using telemedicine. And 35% are definitely saying that they're going to keep using it when everything goes back to normal. And of course, there are benefits and there are challenges to telemedicine. You all know this. A lot of you loved the flexibility telehealth brought to your offices. On top of that, the ability to decrease the unnecessary, and that's the key, the unnecessary face-to-face patient visits was a benefit. But on the challenge side, there were 3 big ones that I'm sure a lot of you were feeling. And the biggest, over 80% of providers said their patients' lack of technology skills was a challenge. And that makes sense, right? We're going from, we know how to talk face-to-face. Now we're talking to our provider on our phones, on our computers. That's hard for a lot of people. And because of that, we saw offices struggle to see as many patients as they were used to. And what that means is they're not bringing in the same amount of revenue to their offices. So we've got all the other challenges, and now we've got money in it. And that's so much stress. And the third challenge, you were tasked with diagnosing remotely. And that's not how we're wired. That's not how we're trained. We put our hands on our patients. We engage our patients. We comfort our patients. And we weren't able to do that as easily across the screen. And to really put in, again, I'm a numbers person. I love numbers. To really put in to context the increase of telehealth, just for Blue Cross Blue Shield of Massachusetts, small, daily claims increased by almost 19,000%. That is crazy. Daily claims went from about 200 per day up to 38,000 per day. That's nuts. So this isn't going anywhere. We've seen that both offices and institutional in-person visits were started to pick back up again, but we're still below that baseline that we had before the pandemic started. We see the reciprocal too. Telehealth visits have dropped by about 30% since their pre-COVID peak, but these remote visits are still up by over 50%. So they're not going away. And we're seeing a shift into this new normal for pharmacies also. In a study that was conducted earlier this year, 56% of pharmacies said that they're fully expecting an increase in the scope of practice as a result of the pandemic. And they believe that this increase includes acting as testing sites, which we've all seen, offering at-home delivery options, which a lot of us have seen, and figuring out ways to keep up the supply chain pressures. And that's a big burden on a lot of our pharmacy partners. Pharmacies are shifting to health hubs. These pharmacies are bringing on advanced practice nurses and other medical staff to really provide quick diagnoses. And this is providing the pharmacists an opportunity that they haven't been able to really capitalize on. And that's to practice within the full extent of their license and provide more patient education. And lastly, is pharmacies they're really relying on technology. So many payers have relaxed and changed their benefit requirements and regulations. That's a lot to keep up with. Pharmacists are now relying more than ever on electronic prior authorizations and drug switching capabilities in their vendor software to use real-time data to really mitigate some of these access barriers and to keep up with everything for their patients. And luckily, everything that our providers and our payers and our pharmacies are doing to meet the current challenges, we see that our patients are shifting with the rest of us. Patients are realizing that telehealth is more convenient and they are opting to schedule virtual appointments. Again, that's for those unnecessary office visits. If it's necessary, they're going to the office. And what we're seeing is patients are seeking out price transparency and affordability options. They're really engaging with prescription drug comparison websites and apps. And if you put all of this together, patients are taking control of their healthcare, from scheduling to accessing a larger network of providers through telehealth. And now they're managing their records and where that pharmacy, where their script is going. They're moving from on-the-spot decision making to having the time to make a conscious, evidence-based decision on in their care. So where are we going from here? We've talked about a lot. So what does it all mean? Telehealth is here to stay. In the midst of the pandemic, many of you, many of professions who thought their jobs couldn't be done from home suddenly found it possible. In these professions, healthcare, we really followed suit. We have patients renewing their prescriptions from home. They're receiving dermatologic diagnoses from home, and they're even doing physical therapy from home. They don't have to leave their homes and go out into this world that's still a little bit of a scary place. And telehealth doesn't replace putting your hands on your patients and working through the complexities that patients bring to us. But for a lot of situations, it just makes sense. And this is creating a world where rural Americans and Americans who struggle with access to healthcare, it's opening the door for them and allowing them to reach high quality care. Pharmacies, they're going to be stepping up the way they communicate with providers and patients and payers. And the key here is patience. patients have already seen their pharmacists. They already see them up to 10 times more often than their provider. In our most recent survey, we found that 72% of patients are regularly asking their pharmacist questions about their medications. And a quarter of those patients have relied more on the pharmacies and the pharmacists to provide information on their condition and their medication since the onset of COVID. And there's definitely an opportunity here as we really work to continue integrating telehealth. Just over half of patients reported that virtual communication with their pharmacy is something they would love to see added to that telehealth experience. So we've already mentioned that it's becoming more necessary for folks to rely on prescription price tools to help decrease that barrier of access to their medications. Just over a third of patients consider the ability to compare prescription cost and payment options as part of that journey now. It's becoming normal. And that's huge. When else do you engage in a monetary transaction where you don't have the opportunity to compare prices, right? Mortgage rates, we can compare rates. We can shop for the best mortgage. Cars, easily you can online, you can see hundreds of cars. Landscapers, we can get different quotes. If you want to buy a TV, you can look at all the options and the prices. And friends, we can compare prices on eggs at the store. There's very little outside of healthcare where you're completely blinded until you show up to pay or you get that bill. And this should be a right. Patients should be able to consider what pharmacies and how much the scripts are out there. They should be able to consider that cash price of their medication if they have insurance versus the copay. Because in some situations, if you're on a high deductible plan and you're not getting a lot of care throughout the year, the cash price may make sense to you. So this is such a great shift in the right direction for patients. One thing that patients are really loving is longer prescription fills. States and payers, they've relaxed some of the quantity limits in order to reduce trips to the pharmacy. Patients that would normally receive 30-day fills are now receiving 90-day fills. And this is one of the things that we've seen is almost 2/3 of patients with a chronic condition or who is caring for someone with a chronic condition would love to see this continue. It makes things easier. It's a positive adaptation that the healthcare industry has made. And we've seen this in the data. 8 months into the pandemic, retail pharmacies, 90-day fills are still up by 7%, while 30-day fills are down by about 12.5%. Batman loves all the new technology. So we've shifted a lot. We've made some lasting changes that'll have a great impact in our industry, but we still have the opportunity for better improvements, continued innovation. Technology needs to really be embraced. Telehealth has been around for years. Adoption really hasn't. On the 11th hour, with a pandemic changing every possible facet of our lives, we're relying on you, all of you wonderful providers, to essentially build the plane as we were flying. We capitalized on this technology framework that's been around forever, and thankfully it's been around forever. But now it's really time to pioneer those next steps to best suit our providers and all patients moving forward. So while there are so many areas of opportunity and continued innovation, we don't have a lot of time left together, so I'm going to leave you with 3. The first is EHR, interoperability and security. We've made a lot of progress in a short amount of time because we were forced. Lack of integration, privacy concerns were large challenges providers faced when trying to implement telehealth after the pandemic began. And I know I'm not telling you anything that you don't know. But so many of our stakeholders have already shown that we can efficiently transcend these previous barriers to really enable patients and providers to connect from afar. And the more systems that talk to each other, the better everything gets for everyone involved. I know we've talked about healthcare disparities today. We've brushed the surface of healthcare disparities today. Black, Latino, Indigenous Americans, they're dying at 3 times bigger rates, greater rates than our white non-Hispanic counterparts. Those are big numbers. Those are scary numbers, but these numbers are just a microcosm, really, of a larger problem. When you look at health measures, infant mortality rates, mental health, chronic condition mortality rates, Black, Hispanic, Native Americans, they fare far worse than white Americans. And just like systemic racism, social injustices, unfortunately, we're not going to be able to fix it overnight. There's a lot of people who would love to do that. But one of the things that we can do right now is to recognize the discrimination is happening and is even in some of the algorithms that we rely on. We need to recognize it and acknowledge it and then do something about it. There's a widely adopted algorithm that's used to refer over 200 million patients to complex care programs. And within this algorithm, the patients that are getting dropped in here, the average Black patient was measurably sick. They're just sicker than the average white patient. And they received $1,800 less annually in care. So if they're measurably sicker and they're not getting as much care as our white counterparts, that's a problem. And this is machine learning. This is algorithms. We've got to do something to make sure the technology that we're really relying on isn't widening that disparity gap. Lastly, patients' access to technology and their understanding of technology. If you go back in time a little bit, if you're a patient and you wanted to view your own medical record, you got to get a subpoena. It's much easier today, thankfully, but we still have half of our patients saying that easier access to their own records is one aspect of healthcare that they would like to see improve moving forward. And we know that over half of our patients say they have access to their medical records through the apps, through online. But it's not a stationary file. If this patient is one of your patients and you use Epic and they go to a specialist who uses Cerner, and then they're going to the pharmacy who's not plugged into either one of those, you have all of these disparate sources that they can access, but they can't put it together. We can't put it together as providers. We have blinders up. We need more EHRs. We need more vendors to embrace and use APIs that are allowing data sharing between applications. And this would really benefit, all of these would really benefit all of the P's in our industry, the providers, the pharmacies, and the payers. And that P that really brings us all together is our patients. So thank you. Thank you for the opportunity to chat with you. And thank you for showing up every day when every day has been really tough. And I welcome the opportunity to be able to answer any questions that you may have.
Awesome. Thank you so much, Melissa. We do actually have a couple questions already. So the first question being, what can be done to reduce or eliminate the disparity among various races or ethnicities?
Yeah, that's a great question. So we just talked about knowing that it exists, right? We all are relying on technology, and gut check that technology. It's just gut check it. If 30% of your patients are a minority, and through this technology, we've got patients scheduling telehealth, we've got patients scheduling in person, you realize that 30% of your patients you're not seeing anymore, check it. Telehealth has the opportunity to affect these gaps. This is a topic that really, I keep giving my perspective for just a little bit, but this is a topic that really warrants a huge discussion in our industry. Telehealth, we used it to create that bridge. Back in the day when it was created, we did so to decrease access barriers. To bring healthcare to everyone, and it has the potential to do that. But folks in rural areas, medication access deserts, are folks in marginalized populations, they may not have broadband connectivity. So you know what, that if we're moving a lot of our patients to telehealth and we still have all these barriers in place, and we're relying on our patients to pick up their phone, they may have fewer digital resources. So just really keep in mind there's, again, this is a lot larger discussion, but it starts with all of us really asking the question, does this pass our gut check? Are we reaching all patients today? Did I reach the patients that really needed me? What other questions?
Yeah, we do have one more question. How can health systems better adapt to COVID-19? Or in other words, what technology optimizations can health systems consider to better accommodate new patient behavior as a result of COVID-19?
That's a great question. How much time do I have now? We could talk about this. Again, this is a huge, larger discussion. But from my perspective, there's three big areas. It's so important now more than ever that our providers have a single, reliable source of truth for all the things for patient and prescribing information. We're surrounded by all of these technology solutions, and you couple that with, we're seeing patients in office, we're seeing them virtually. We may have staff who are out working at home, managing a lot of that post-visit processes, like verifying insurance benefits and things like prior authorization. And just because we're by nature, we're doing all of these things, we're jumping in and out of all of these different workflows, all of these different solutions, providers are becoming overburdened. We need a streamlined way to do all the things in one place. And because we're overburdened and because we're jumping through all of these workflows, things are falling through the cracks sometimes. And these are things that our patients need. So that's one. From a different lens, real-time benefit check solutions can be a game changer right now. Medication regulations, policies, they're changing so fast. It's crazy to think that we can just keep up inherently. Real-time benefit check solutions are going straight to the source. We don't have to keep up. We can check it all in real time. They're also allowing providers to really give information to their patients that brings them into the process and helps really fight that affordability barrier. I could keep going. Are there any other questions?
Yep, we do have another one. Do we have enough data to know if there are, or if the disparities are more from geography, genetics, or other factors?
That's a great question. I'm an epidemiologist. I'm always going to tell you we don't have enough data. We need more data. And it's interesting for what disparities are we talking about? Is it telehealth? If it's telehealth, there were lots of studies. I did a lot of reading to prep for this, and there are a lot of studies that from 15, 16, 2017. But what we talked about, folks weren't really embracing technology in telehealth. But the resources that we saw there, keeping in mind selection bias, right? Because there's not a lot of patients at that time that were really embracing telehealth in offices. We were seeing some of those bigger things like stroke care, cardiac care. There weren't a lot of minority biases. So but you have to think about, we started this 8 months ago. 85% of our provider offices started using telehealth and relying on technology 8 months ago. As an epidemiologist, that's not a lot of time to collect data and really synthesize. From what we're seeing right now, geography is a big barrier. In new issues. Again, there are systemic issues within our healthcare system that are affecting certain minority, racial, and ethnic groups. But the things that we've seen post-COVID, it's geography. It's still that access to healthcare and availability of technology. So even if you say you've got a smartphone, download this app, they may not have the broadband connectivity, and that could be lots of reasons. It could be rural. I grew up in the middle of nowhere, Ohio, and still have friends that live there. They don't have they don't have the technology. They don't have big Wi-Fi. If you do a Zoom call, I got their video muted, and we might be talking over the cell phone because they're just not able to connect. So there's definitely geography. There's definitely, again, racial, ethnic issues that are just a function of our current system, and the pandemic is really extrapolating those and exponentially increasing those.
Great, thank you. I don't believe we have any questions at this time. To give everyone maybe a couple more seconds for any final thoughts or final questions, I will put in a shameless plug here again. And just, Melissa, thank you so much for presenting today. We also want to thank our sponsors. Again, without our speakers or our sponsors, none of this would be possible today or last week either. So we want to thank our platinum sponsors, Fortinet, Cisco, and UpDocs. We want to thank our premier sponsors, CoverMyMeds, Nordic, and VirtueStream. And we also want to thank our elite sponsor, Trinisys. Again, we are eternally grateful for everyone's support and for all of you for attending our virtual conference last week and this week. I'm not seeing any final questions here. So Melissa, we will go ahead and let you go for this afternoon, or let you attend some of our other sessions for this afternoon.